So my name's Annabelle Forsyth. I'm one of the consultants in sexual and reproductive health, and I'm based in the Oxford Sexual Health Clinic. I also work a bit in community gynae, and this is my registrar, which some of you may know, Neda Tagnajadi. She is a CSRH trainee.
Hello.
Hello. Can everyone hear us? The screen seems to have frozen for us.
Yes, thank you.
Still all there. Great. So we're just going to try and screen share and hope that it works. Have you got it up somewhere? So we've got 2 hours to talk. We'll probably try and have a little break in the middle, so it's not bad in a way that we're starting a little early, because I think you might need a break kind of in the middle, because it's quite a long time to concentrate for otherwise. Okay, can you all see the screen? Yeah. It says contraception for gynae. So, it's a bit of contraception. Well, it's mainly contraception and a little bit of sexual health, because our kind of special interest area is contraception. So we have got a bit of STIs in at the end, but I'm afraid it is mainly contraception. So what I thought we'd cover, because often we have quite varying levels of knowledge and expertise in these kind of groups when we're teaching contraception. So we thought we'd start by going over some of the basics. So Ned is going to take you all through just talking through the main contraception choices available for women, a bit about emergency contraception, and then particularly, I think, relevant for you, postpartum contraception, which I know a lot of you are being encouraged to do a lot more of nowadays. And then contraception in the over 40s and the sort of perimenopausal stage of life. Then I'm going to take over and I'm going to do a little bit more detail about certain aspects of contraception. So we're going to have a little talk about what coils are available and how to choose which coil for a woman, help her choose which coil is right for her. Update you a bit on what's going on in the sort of digital world of contraception, transgender contraception, and just a bit about how COVID has changed how we are prescribing contraception at the moment. And then finally, we'll probably have a break at that point and a little quiz just to test your knowledge. And then we're going to try and focus a bit on using contraception for non-contraceptive purposes. So how you can use contraception, particularly within gynae, for to manage lots of other conditions. And then we have some case studies at the end, which are a bit more STI related. So it's quite a lot to get through. We'll see how we go timing wise. And please do feel free to interrupt and try and make it as interactive as possible. I know that's really difficult when it's remote. So I'm going to stop talking and hand over to Neda.
Thanks very much, Annie. So I'm just going to take my mask off for this chunk. So for this first section, I'm just going to take you through some of the very basics of different methods of contraception. And that's just because there's likely to be a bit of variation in everybody's baseline knowledge. So just to get you all up to speed before and on the same page before we go through some of the finer details. So in this talk, we're going to talk about these 6 methods of contraception. There are, of course, other methods of contraception available, diaphragms, caps, etc. We're not going to talk about those. We're going to focus on these 6. So just a few highlights from each of these methods of contraception, starting with progesterone-only methods, a very common one of which is the mini pill or the progesterone-only pill. Okay, so there are, broadly speaking, 2 different types of progesterone-only pill. There are traditional POPs and the newer or desogestrel POP. And they vary slightly in their mechanisms of action and in their window periods. Okay, so desogestrel is probably the one that you come across more commonly. So that's the newer type of POP. The way that desogestrel works as contraception is that it stops ovulation. Okay, so it's anovulatory. It also has those other progesterone effects. So those would be thickening of the cervical mucus and thinning of the endometrial lining. It's got a somewhat less generous window period than the combined pill of 12 hours. So you're late or you've missed a pill of desogestrel POP if you're more than 12 hours late. Some of you may have seen prescriptions for traditional POPs. So those are things like Noriday or norethisterone being a common one. So with traditional POPs, their main mechanisms of action is actually that they thicken the cervical mucus and thin the endometrial lining. So they're not anovulatory in a huge portion of people who take them. They have a slightly less generous window of 3 hours. OK, so you're late or you've missed a pill if you're more than 3 hours late. One way to remember this is this little picture that I've included, generation gap. So remember the traditional POPs, a slightly tighter, narrower window period, and newer types of desogestrel, a slightly more generous, looser window period. OK. So I've included this little caution in the bottom right corner regarding medications. Does anyone know why I've included that or what I'm alluding to there? Feel free just to shout out.
Is it liver disease?
Yeah, sort of. So there are certain medications that can induce liver enzymes, aren't they? So enzyme-inducing medications. So the progesterone-only pill is not suitable for anyone who's on enzyme-inducing medication because that will reduce the efficacy of the POP. Okay. Other progesterone-only methods. So there's also the implant. So the implant is a small kind of rod-shaped device that has a type of progesterone called etonogestrel that it releases slowly over 3 years. The mechanism of action of etonogestrel is that it's anovulatory. It still does those other progesterone-only side effects, so it does thicken the cervical mucus, it does thin the endometrial lining, but its main mechanism of action is that it stops ovulation. In fact, it's so good at stopping ovulation that it's the most effective method of contraception. It's even more effective than sterilization. So that's just a little reminder. That hands up there is a reminder that it is the most effective form of contraception. As with any progesterone-only method, it does have a lot of the progesterone-only side effects also apply to the POP and some of the other methods that we're going to talk about. Does anyone know what those progesterone-only side effects are?
Weight gain.
It can be associated with weight gain.
Acne.
Skin changes, yeah.
Breast
Changes in
tenderness.
mood.
Breast tenderness and changes in mood, absolutely. So every time that you're prescribing someone a progesterone-only method, remember to counsel them about those hormonal changes. So skin changes, weight changes, changes in mood, and breast tenderness. Excellent. And I've included that medication picture in the corner as well as a reminder again that it is affected by enzyme inducers. So the implant is again not suitable for people who are taking enzyme inducing medications. So next progesterone-only method, the injection. So the injection, the common one that we use is a medroxyprogesterone acetate. It's a high dose of a progesterone that is injected IM, and it's given approximately every 12 weeks. Okay, so this progesterone-only method is again anovulatory, so it stops ovulation, but it does have some of those other progesterone effects as well, so thickening the cervical mucus and thinning the endometrial lining. So same rules apply in terms of progesterone-only side effects, so skin changes, mood changes, breast tenderness, weight gain. I've included this picture at the bottom regarding weight gain, just as a reminder that actually the injection is the only method of contraception for which there is quite strong evidence that it is associated with weight gain. Okay, so for women whose absolute priority is avoiding or minimizing the risk of weight gain, this is not the best option. I've also included this little skeleton picture here. Why have I included that? Does anyone know? What other adverse effects? Oh, sorry.
Osteoporosis.
So long-term use of the injection is associated with decreased bone mineral density. Exactly. So for people who have other risk factors for bone mineral density or people at very young or older age, it might not be the most suitable method. And what picture is missing from this slide?
The liver inducers.
Yes, it is not affected by enzyme-inducing medications, so it is suitable for people taking those. Excellent. So, so the final progesterone-only method contraception that I'm going to talk about is the IUS, or the intrauterine system. There are lots of different types: Mirina's, Levoset's, Jades, which Annie is going to explain to you in further detail later. So in terms of its mechanism of action, the IUS thickens the cervical mucus and thins the endometrial lining. It's usually not anovulatory, okay? So only 25% of people stop ovulating with the IUS. So it's a localized release of progesterone hormone, and in general it lasts for 5 years, although we'll talk about that again in a bit more detail later. It's an excellent form of contraception and especially good at reducing blood loss. So it's a treatment for menorrhagia. And that's why it really is a gynecologist's best friend. So it's used for lots and lots of different medical indications, including being first-line recommendation for management of menorrhagia. And also, as we'll talk about later, very useful around the menopause as well. So again, I haven't included that medication picture because it is not affected by any enzyme-inducing medications. Can the IUS cause any of those other hormonal methods that we've spoken about?
Yes.
Yeah, it can. So any hormonal method can. Even though it's a much lower dose compared to things like the implant and the injection, there is the possibility of systemic effects from the progesterone. And those again would include weight changes, skin changes, breast tenderness, and mood changes. Okay, so that's all of the progesterone-only methods. And now we're going to talk about combined hormonal methods. Now, the one you probably come across most commonly is the combined hormonal pill, but there are other types of combined hormonal contraception. For example, what I've included here, so the patch and the vaginal ring. Actually, very hard to get the vaginal ring in Oxford, so I think it's off the formulary in most regions, so we don't see many patients with the ring. How does the combined pill work as a method of contraception? It is anovulatory, okay, so it stops ovulation. So what are the good things about the combined pill? So often it does have quite a few positive kind of side effects. And I've included this picture here just as a reminder that a lot of the types of combined pill are quite skin friendly and they are often used for this indication, okay? But I've just put a little caution here. Every time you're prescribing the combined pill, even more so than other types of contraception, I want you to ask yourselves, is this safe for that patient? Why have I put that reminder in?
Risk of clots?
Yeah, absolutely. Risk of VTE.
You can't give it to people who have migraines and...
Yeah, migraines with aura. Absolutely. It's contraindicated in patients with migraines with aura.
Previous history of
hypertension?
Yeah, I've heard the words hypertension and somebody else said something as well.
history of cancer.
Yep. So I think the overall message with the combined hormonal methods is that there are more contraindications for combined methods in comparison with other forms of contraception, okay? And it is in a way kind of associated with higher risks of other types of conditions, okay? So in terms of the contraindications, one of the most common ones that we come across is people with a history of migraines with aura. And the reason behind that is that there's lots of evidence demonstrating that if you give combined hormonal methods to patients experiencing migraines with aura, that subset of patients have a significantly increased risk of stroke. Okay, so that's the reason for that contraindication. And also patients, for example, with a personal history of VTE, breast cancer. The UK MEC, so that's UK MEC, is a really useful document which clearly outlines all of the contraindications for using combined methods. In terms of risks, so the evidence around some of this is not completely clear, but it does look like combined methods are likely to slightly increase risk of hypertension, stroke, breast cancer, and possibly cervical cancer. On the other side, though, combined hormonal methods do seem to reduce risk of ovarian cancer and bowel cancer. It's important to counsel patients about both of those aspects, okay? And why have I included this picture here? Because it is affected by enzyme-inducing medication. So all of the combined hormonal methods, that includes the patch and the ring, are reduced in terms of their efficacy by enzyme-inducing medications. Okay. Now, finally, non-hormonal methods. Now, as I said earlier, there are other types of non-hormonal methods, like the diaphragm and caps, but I'm just going to talk about the copper coil here, okay, as this is the only non-hormonal method of contraception with a high degree of efficacy. So a copper coil, depending on the size, can generally be used for 5 or 10 years. The copper on the frame of the device is toxic to egg and sperm, and even if they do meet, it prevents implantation or significantly reduces the risk of implantation. So benefits of the copper coil, no hormones. So if patients want to avoid any of those possible hormonal side effects, it's a really great option. But what's the one trade-off when it comes to the copper coil? Why have I included this picture? What's the downside?
Heavy bleeding.
Exactly. So menorrhagia, dysmenorrhea, and that's a very common side effect. So most patients do get slightly longer, heavier periods. Okay. Now, I've just included some information here about the different failure rates of various methods of contraception, okay? And I just want to draw your attention to demonstrate this point really. Male condoms with typical use, the failure rate, so that means women experiencing an unintended pregnancy in a year of use, of typical use, is 18%, okay? And if we compare that with the implant, you can see with typical use, that's 0.05%, okay? And that's actually lower, significantly lower than the failure rate of sterilisation. The WHO also has a nice chart just demonstrating the differing efficacy for all these different types of contraceptive methods. And you can see here, we're going from withdrawal to male condom to things like the injection, pill, patch, ring, which are user dependent, and then moving on, highest efficacy for the implant, vasectomy, sterilisation, IUD, which are not user dependent. Okay, so before I move on to emergency contraception, any questions so far about some of the basics of the different contraceptive methods? No messages on the chat? No, okay, I'll just keep going. So, emergency contraception. There are, broadly speaking, 3 different types of emergency contraception. That is the levonorgestrel pill, ulipristal acetate, which is also a pill, and the emergency copper coil. And we're going to talk about each of those. So one of the most common types of oral emergency contraception prescribed is levonorgestrel, 150 micrograms. You might have heard it referred to as Levanel. In America, it's usually referred to as Plan B. So levonorgestrel is licensed for up to 72 hours post unprotected sex. The way it works is it prevents or delays ovulation, and how it does this is that high dose of synthetic progesterone delays the LH surge. Okay, so it delays the LH surge, thereby delaying ovulation. It's an extremely safe medication. It can be taken several times within a cycle, and even if there's a chance of an early possible pregnancy. Okay, so it's not thought to be associated with adverse pregnancy outcomes. Generally very safe and few side effects. The ones that patients might report would be a headache, possible nausea, and if they vomit within 2 hours of taking it, they need a further dose. The next period might be altered in pattern, so they might get a later or lighter period. So it's really important to counsel people and safety net them to make sure they do a pregnancy test if their next period is altered at all in pattern. As I said, very, very safe, so it's completely fine with breastfeeding. If a patient is on enzyme inducers or has a BMI of over 26, we would recommend giving double dose, okay? So sorry, it's BMI of more than 26 or a weight of 70 kilograms or more. And I would say that's a huge portion of our patients, okay? So we're often giving double dose levonorgestrel, okay? Great. So ulipristal acetate, this is another method of morning after pill, so emergency hormonal contraception. Often referred to as ELA1, it's one of the trade names. So ulipristal acetate is a synthetic progesterone receptor modulator. Okay, so slightly different mechanism of action relating to levonorgestrel, but in essence, it still does delay the LH surge and therefore delay ovulation. It has a more generous window period, so it's licensed up to 120 hours after sex. It's more effective than levonorgestrel, okay? And the reason for that is that it can delay the LH surge even after it's already begun. Okay, so it's more effective than levonorgestrel. So why don't we just give ELA1 to everyone or ulipristal acetate to everyone? So the reason for that is it's got a few more contraindications and cautions around its use. Okay. Because it's a receptor modulator, the interesting thing about ulipristal acetate is that its efficacy can be affected by any other circulating progesterones. Okay, so when might that be clinically relevant?
If she's
take.
I suppose if somebody's worried about unexpected pregnancy because they've been missing doses of the POP.
Yeah, absolutely. So if somebody has been on hormonal contraception, sorry, that was Callum, one of our F2s in the corner. Thank you, Callum. So if somebody has been taking hormonal contraception, but they've missed a few pills, but they think they've taken some within the last 7 days, then that circulating hormone might activate the progesterone receptors and stop ulipristal acetate from working, i.e. it will compete with ulipristal acetate. Equally, if you're about to prescribe someone ongoing hormonal contraception, that contraception that you prescribe on the same day could interact and actually compete with the ulipristal acetate and stop it from working, okay? Also, it should be avoided in people who are breastfeeding. So it goes into the breast milk and it's unclear what the effects of that are on the neonate. So if someone is breastfeeding, they would have to express and dump that milk for 7 days. Also, if someone is a severe asthmatic who's taking oral steroids for their asthma, ulipristal acetate should be avoided. This is because it has some mild glucocorticoid effect, and what we don't want to do by giving it is precipitate a life-threatening asthma attack. It should be avoided in patients who are taking enzyme inducers because the efficacy around that is unknown. Okay, and finally, moving on to the emergency IUD. So hopefully what's been clear from what I've said already is that both of the oral types of emergency contraception only work pre-ovulation, okay? So they have no effect at all if someone's already ovulated. The only method of emergency contraception that works after ovulation is the emergency IUD. So the emergency IUD, the copper IUD, is toxic to egg and sperm and also prevents implantation. So if someone's already ovulated and the egg has been fertilized. It can be inserted up to 5 days after a single episode of sex or up to 5 days after the earliest expected ovulation. Now, why do we have those rules? If you remember why we have them, it'll help you to remember them. The reason we have them is because what we want to do when fitting what we want to avoid when fitting an emergency copper coil is inserting that copper coil when implantation has already occurred. Okay, so we know that in general, I think the earliest time for a fertilized egg to become implanted is about 6 days. So we take a more conservative measure, we say 5 days. We avoid fitting a copper coil if there's a possibility of a fertilized egg which has implanted 6 days after ovulation. Okay, so I hope that makes sense to everyone, and we'll do some case studies to just look at that in a bit more detail, or some quiz questions. The good thing about the emergency IUD is that provides immediate ongoing contraception, which is great, and is by far the most effective form of emergency contraception. Okay, so far superior to ulipristal acetate and levonorgestrel. Okay, any questions about emergency contraception or anything that Annie you'd like to add? No, nothing in the chat. Okay, so I will keep going on. So now we're just going to talk about methods of contraception for different populations. So the ones that I'm going to talk about here are contraception for people who are postpartum and contraception for women over the age of 40. So starting with postpartum contraception, there is a really excellent guideline on the Faculty of Sexual and Reproductive Healthcare. That's the FSRH guideline, Contraception After Pregnancy. Some of you may have come across this already if you're considering, for example, doing your part 1. It's a long document. It's sort of, I think, 98 or 99 pages long. So we're just going to give you some of the highlights from that document. Okay, why bother having a separate guideline for people who are postpartum? Well, that's because we know that there's a really high level of unmet need for contraception in this population group. We know that fertility can return very soon after a pregnancy, although women often don't know that. We know that short inter-pregnancy intervals are associated with maternal and neonatal morbidity, and in fact, the WHO recommends waiting 2 years between pregnancy. And I should actually update this. Last time we gave this talk, postpartum contraception was not provided at all at OUH, although we've made a lot of development in that area in the last year, and now patients can get the depot and the mini pill, which is great. Okay, so just a few different reasons also why it's slightly more complicated to prescribe contraception to people who are postpartum. So can anybody tell me what the cautions are or what we're worried about when prescribing contraception to women postpartum? There are some prompts here, of course.
Breastfeeding.
Absolutely. So we're worried about breastfeeding and the effect on the neonate.
Clotting risk.
Clotting risk, yeah. So we know that people who are postpartum are already high risk of VTE and we don't want to exacerbate that risk.
Perforation.
Changes in the uterus, contractions of the uterus.
Absolutely. So changes in the uterus that might make risks of putting in a uterine device slightly more risky. So for example, perforation, absolutely. Okay, so we're going to talk about each of the methods of contraception and what we can and can't do for the postpartum group. So starting with these three methods of contraception, in summary, there are no real restrictions for the use of these three methods postpartum. Okay, so the mini pill implant and the injection. So not demonstrated to have any adverse effect on lactation, infant growth or development. They can be started any time after delivery. The mini pill and the implant are not associated with any increased VTE risk. There's a query around increased VTE risk with the injection. It certainly hasn't been demonstrated to increase your VTE risk to a very high level, but there have been some observational studies demonstrating a very small possible increased risk. So this is an extract from the UK MEC, which is the UK Medical Eligibility Criteria. For those of you who haven't seen it before, it gives you a number for each method of contraception and each different kind of condition or state. So a 1 means that there's no restriction to use, and a 2 means that the benefits outweigh the risks. So you can see here that for the implant, the depot and the progesterone-only pill, they're all 1s and 2s for people who are postpartum and breastfeeding, okay? So it can be prescribed immediately to anyone who is postpartum. You can see this light 2 here, that's just a caution in terms of VTE, but the guideline does say that the benefits outweigh the risks. Did someone have a question? Sorry, someone just, I could hear something. Yeah, okay. So moving on. With the copper coil and the IUS, there are some restrictions in terms of their use. So, not demonstrated to have any adverse effect on lactation, infant growth or development. But in terms of the timing, we need to determine when we're going to fit those coils. So either coil can be safely inserted within 48 hours of delivery or after 28 days, okay? And the reason for that is partially due to worry about perforation between 48 hours and 28 days. And finally, the combined pill. So this is the method, again, that generally has the most restrictions for its use, and that definitely applies to the postpartum group. And why is that?
Estrogen gets into the breast milk.
There are some concerns about breastfeeding, yes, but the main reason is VTE risk, yes. So you can never start the combined pill immediately following a delivery, and that's because the VTE risk is too high, okay? So you always delay starting the combined pill. We say delay until 6 weeks if breastfeeding or additional VTE risk. And those VTE risks would be things like smoking, PPH, high BMI, having a section, transfusion, immobility, or a history of preeclampsia. And just looking at that in more detail, so you can see here that you can start in some people from 3 weeks if they have absolutely no risk factors for VTE. But for anyone with a risk factor, you would have to wait until 6 weeks. Okay. Let's just touch on lactational amenorrhea, which is another kind of method of contraception. So lactational amenorrhea describes a state in which people are breastfeeding and that induces anovulation and therefore is effective at preventing pregnancy. So the criteria that you need to meet to be in a state of lactational amenorrhea kind of officially is that it has to be within 6 months of your delivery. You must be fully breastfeeding. Okay, so this does not include people who are partially breastfeeding, and you must be amenorrheic. And if you meet those 3 criteria, the failure rate is pretty good. Actually, it's less than 2%. What do we mean by fully breastfeeding? So we mean day and night, not using any other kind of frequent liquids, and no long intervals. So no more than 4 hours in the day and no more than 6 hours at night. In general, when do we start contraception after delivery? So that we know the pregnancy risk, unless somebody meets the criteria for lactational amenorrhea, is by 21 days after delivery. So we often try and start contraception before day 21. But remember those exceptions. So the combined pill, 3 weeks or 6 weeks, depending on other VTE risks, and the IUS and the IUD needs to be before 48 hours or after 28 days. Okay, any questions about postpartum contraception? No. So I'll keep going and talk about contraception for the over 40s. Yeah, oh, someone's hand is raised.
Yeah, sorry. I just wanted to know if there's any good evidence now about like putting coils in after cesarean sections. I know a couple of units have started to do it, but there wasn't much evidence on the efficacy and how many actually were still in at 6 weeks. So I just wanted to know if there was anything you were aware of about the efficacy of that.
Yeah, that's a really good question. There's been a really large scale international study that's looked at coil insertions at sections around the world. And actually what it's demonstrated is that, first of all, it's very, very safe. So extremely low risks of infection. With regards to expulsion, it seems to be roughly equivocal actually to inserting it post a vaginal delivery. So you're more likely to expel a coil if it's inserted at C-section than if you're just not postpartum, but it's still roughly the same as having it inserted after a vaginal delivery. And on balance, I think if you explain that to women, they'd often like to take that chance because in the end, even if they hadn't had that coil fitted at the time of section, they'd still have to come back to have one refitted if that makes sense. So that's often a trade-off that women are willing to kind of accept. One of the downsides with inserting it at C-section is that there's a fairly high rate of lost threads. So there's one study in Scotland actually which demonstrated a rate of lost threads of around 30% actually with the coil at section. And that's partly due to the way that you insert it. So when you put it into the uterus and then close the uterus, you have to, before you close the uterus, you have to feed down the threads down the cervical canal, which can be really tricky. But I think, the important thing is counselling women about these increased risks. In my experience, most of them would still rather have it done at section than come back postpartum and have a kind of a vaginal procedure, and just make sure that they kind of have access to good follow-up. Does that answer your question?
Yeah, definitely. I think the problem that I noticed was the lost threads, because it's really hard to thread it through a closed cervix. You have to dilate the cervix.
It is.
But thank you. That really helps. Thanks.
No problem. Just building on the lost threads kind of conversation as well. The study that looked at this in Scotland and found kind of a rate of 30% of lost threads. One thing that they theorised was that as women start to bleed or have periods, once they've stopped breastfeeding, for example, especially with the copper coil, it might be the case that some of that blood flow actually helps the threads to descend. So they're going to be publishing some data looking at 6 month and 1 year follow-up, and it'll be interesting to see whether the rate of lost threads changes with that. Okay, so moving on to contraception for the over 40s. So again, the FSRH have a very helpful guideline specifying some of the details around contraception for women aged over 40 on their website. Why do we bother having a separate guideline? Because we know that the background risk of cardiovascular disease, breast disease, and gynecological disease is increased in this group. And because we know that becoming pregnant or going through childbirth in this age group is again much higher risk for both mother and for baby. Okay, so again, just the same process. I'll go through each different method of contraception and some of the different cautions around their use. So the mini pill. The mini pill is so reliably safe in pretty much every group. That's why we love it. So there are essentially no restrictions for the mini pill use in the over 40s. Again, it's not associated with increased risk of VT, stroke or MI. It's not shown to affect bone mineral density, and it can be used at any age. So the progesterone-only pill is always a safe bet. The implant. So again, a lot of the same rules apply, not associated with increased risk of VTE, stroke or MI, not shown to affect bone mineral density, and again, can be used at any age, so no restrictions for its use. Now the injection. So the injection, as I said earlier, talking about the postpartum patients, there may be a slightly increased risk of VTE, and that was following a 2016 systematic review, mainly looking at some observational studies. Okay. Evidence regarding risk of stroke, MI, and breast cancer is really conflicting. So it's difficult to counsel patients regarding that. There's no strong answer really either way about what the risk is. And we do know that it can cause loss of bone density. Okay, and that's why the FSRH basically says, oh, sorry, I'm just going to, I can't quite see because of this black thing, that the use is restricted in women over the age of 45 and under 18. Okay, so you can still prescribe it in those age groups, but it comes up as a UK MEC2. Benefits generally outweigh risk, and that's a conversation that you need to have with your patient. Okay. Now the IUS. IUS has little or no increased risk of VTE, stroke, or MI. Again, slightly conflicting evidence. Again, conflicting evidence on association with breast cancer. An association with breast cancer has not been ruled out. And the FSRH supports extended use of the IUS until age 55 if it's inserted at age 45 or over. Similarly with the copper coil, the faculty supports extended use. So if it's inserted at the age of 40, it can be used until contraception is no longer required. When is contraception no longer required? We're going to come back to that a little bit later. Okay, and finally the combined pill. Now again, this is the one with the most restrictions for its use. What we would say is that if somebody over 40 wants to keep taking the combined pill, we would recommend using a newer generation type of progesterone because they're associated with lower VTE risk, for example, levonorgestrel and norethisterone, and we'd recommend using a combination with a lower dose of ethinestradiol, a lower dose of estrogen, so under 30, okay? Extended or continuous regimens can be offered to control menstrual or menopausal symptoms, which Annie is going to talk about a bit later on. And we can see there is a slight restriction for use, so it's UK MEC2 if you're aged over 40. Okay, so risks outweigh benefits, but you need to have that conversation with your patients. It cannot be prescribed to anyone who's over the age of 35 and a smoker. Okay, so it is not permitted to be prescribed to that age group if they're smoking. So just a little summary of what we've said. So mini pill and implant, no restrictions for use. The injection becomes UK MEC2 when the woman's aged over 45, and that's in part because of bone mineral density as well. The combined pill becomes UK MEC2 over the age of 40, and we know there is an increased risk of VT, MI, stroke, breast cancer. And remember, if they're smoking, you can't give it after the age of 35. And the copper coil and the IUS both have extended use for this age group. So when do we stop contraception? There are some general rules around this. So you can stop contraception if a woman's aged 55 or over. You can stop contraception if a woman is 50 years or over and has been amenorrheic for 1 year, as long as they're not on a method of contraception that stopped making them amenorrheic. Or if they're under 50 and they've been amenorrheic for 2 years. Okay. So what about people who are on a progesterone-only method and have therefore had induced amenorrhea? How do we know if we can stop contraception? Well, the faculty says that we can measure their FSH level, and if the FSH level is raised above a certain level, we can advise them that they can stop contraception in a year. Does anybody know what that FSH level threshold is?
Is it 30?
Almost, it's 40. That's right, isn't it, Annie? Is it? Oh, is it? Oh, I thought it was 40. Sorry, it is 30. You're right. I will double check, but I think you're right. Extended use of the copper coil can be used if inserted over the age of 40, and a Mirena IUS can be extended if inserted over the age of 45. So, what about use in the menopause? You must remember that sequential HRT should not be relied upon for contraception. But all progesterone-only methods are safe alongside HRT. The only one that's actually licensed, the only form of contraception that's licensed to be used for endometrial protection for HRT is the Mirena IUS. And if it's inserted for this indication, it must be changed every 5 years. So you can't use extended use. You can't rely on extended use of the Mirena if someone's using it for endometrial protection for HRT. Okay, so that's quite a lot of information. Does anybody have any questions? And I'm just going to double check about that FSH level as well in a minute. Lydia.
Hi, sorry, one more question.
Yeah, of course.
Would you have to use like another intrauterine system like the JDES or something? I know they're not licensed, but
yeah,
would they work as effectively? And
that's another really good question. So if you use it, so first of all, it would certainly have to be a 52 milligram IUS. Okay, so the other 52 milligrams IUS, which Annie's going to talk about, is the Levocert. Okay, so we wouldn't recommend looking at or trialing something like the JDES because the dose of progesterone is significantly lower, so it's not going to provide as good endometrial protection. Okay, now, although we can theorize that the Levocert is likely to be just as good as the Mirena at protecting the endometrium for HRT, because they're the same dose and they're the same size, that hasn't been demonstrated yet. And so the guidance is rather conservative and it recommends only using a Mirena if it's for HRT. Okay, but it's very likely that the Levocert, which is the same size of dose, will do the same. We wouldn't recommend ever kind of considering other lower dose IUSs because the dose of progesterone is so low.
Okay, thanks.
No problem.
We've got a question from Veronica.
Veronica, thanks, Annie.
Yeah, thank you. I just have a question that often gets asked when you're talking to women about contraception, and they're often asking how long, like once they stop the pill or the Mirena is taken out, like how long it takes for their cycle to sort of resume if thinking about trying to get pregnant again.
Yeah, good question. So it does vary from women to women. What I would say for people who are taking any pill or the implant or the IUS is that it would usually on average just take a few weeks. Okay, sorry, I should say days to weeks. So it could take a few days to weeks for fertility to return. The exception, however, is with the injection, where there can be quite a delayed return to fertility. So with the contraceptive injection, it can sometimes take up to a year for normal cycles to return. Okay, so for most methods, days to weeks. The copper coil actually immediate, and the injection can be up to a year. What I would say, however, is whenever you're removing a method of contraception or a patient is stopping a method of contraception, you must counsel that patient to treat themselves as if their fertility is returning immediately, because we don't know, they could really ovulate at any time, and we don't want them to have an unintended pregnancy. Does that answer your question?
Yeah, thanks.
No problem. Okay, so shall we move on to Annie's section? Let me give you this chair. Thanks.
Okay, so thank you, Neda. I think that was good to get a few of the basics covered. The next section is a slightly more detailed look at a random selection of things, which basically we thought would be quite useful for you and quite interesting, hopefully. So talking a bit about which coil, how to help a woman choose the right coil. So she's decided she wants an intrauterine device. Where do you go from here? So it used to be really easy, didn't it? It used to be basically two choices, Mirena or a copper IUD. But we've got a lot more choice available to us nowadays. So in terms of the IUS, as we've already mentioned, we've got the JDES. We've now got a newer device called the Kylena, which I'm going to talk a little bit more about. And then we've got the Levocert. We've got slightly different sized copper IUDs. So this is a 5-year one called a mini TT, and the one on the far left is a T-Safe. That's the 10-year coil. We've got different shaped copper coils. So this is a Gynaefix, and I'll talk a little bit more about that and how it's inserted into the uterus. And then more recently, this rather attractive ballerina has come out, which we're starting to see sort of, we don't have it yet, unfortunately, in our clinic, but we're starting to see women filter through who've been seen abroad and had these ballerinas inserted. So we're going to do just a couple of slides at looking at comparing the various coils. So firstly, the Levocert and the Mirena. So the Mirena, hopefully you all know quite a lot about. It's a coil that is licensed for 5 years as contraception, and it is also used for up to 5 years as the progesterone component of HRT. It contains levonorgestrel, 52 milligrams. And I'm sure you're all very familiar with inserting them. It's licensed for HMB, it's licensed for endometrial protection. And I think, you know, they're really user-friendly, fantastic things. We love them. We now have the Levocert. So the Levocert is essentially pretty much identical to the Mirena. So it's got exactly the same hormone. It's got exactly the same hormonal dose. It's the same frame size. So the T is exactly the same size. The inserter tube is ever so slightly wider. And the inserter device has a slightly different mechanism, but it is much cheaper than the Mirena. So in our community clinics, we use a Levocert as a first line and a Mirena as a second line. It is licensed for heavy menstrual bleeding. The only thing that it doesn't yet have a license for is for endometrial protection, which I imagine probably will come about. But for the time being, for women who need endometrial protection, as Neda just discussed, the advice is to put a Mirena in. But otherwise, we're using Levocert as the first line. The other benefit of the Levocert is that they are currently applying, they have the data for the 6th year, that it is a highly effective method for up to 6 years, and they've applied for the license for that 6th year, so we're expecting that to come through soon. So lots of women out there will get a bonus year on their Levocert. The Kylena and the JDES are produced by the same company as the Mirena. So the JDES you probably all know a little bit about. It's been about a bit longer. It's a much lower dose of levonorgestrel. It's a smaller device and it's got a smaller tube inserter. Licensed for 3 years. It is not licensed for heavy menstrual bleeding and it's not licensed for endometrial protection. It does tend to make women's periods lighter, but it is less likely to make them go away altogether than the Mirena. We find it useful for women who are uncomfortable with a Mirena in, so those ones that continue to have niggly pain and you can't find a cause, and you think, well, maybe they're a nullet with a small cavity, the Mirena is just slightly too big. You can choose to put a JDES in, and sometimes that's just a bit more comfortable for them. But the majority of women will tolerate a Mirena very well. The Kylena, we think is going to be a really good addition to our contraceptive armory. We haven't yet got it in our clinic, but it's basically the same size as a JDES, but it has a higher level of hormone, a kind of hormonal level in between the Mirena and the JDES, in a really small device with a license for 5 years, and again a bit cheaper than the Mirena. So encouraging people to think about maybe using those in the future as well. Again, not licensed for heavy menstrual bleeding or endometrial protection, so perhaps slightly less useful from the gynae side. So this is just the Levocert, just a little bit about the inserter device. So I don't know if any of you out there have ever seen or fitted any copper coils, but the Levocert's a little bit more like some of the devices for the copper coils. So it is a two-handed device, so it's just a slightly different technique. The ballerina is, again, that's kind of been designed for women that like the idea of a non-hormonal IUD, but they have been uncomfortable with a T-shaped device in. So some women find that with a T-shaped device, they just get that niggling, persistent pain, that maybe the device is just slightly too big for the cavity. And so different shaped devices can be really helpful for those women, so frameless devices. So the ballerina looks like a little bit like one of those like plug things that you plug chains, yeah, or Christmas tree decoration. But it comes in kind of straight in a tube, and then it sort of pops out as you put it in the uterus, and becomes this 3D ball device. There are 3 different sizes. Unfortunately, the small size are shown to be have quite high rates of expulsion, but the middle and the larger size seem to be, from early data, seem to be very effective and have lower rates of expulsion. So you may come across women who have these coils in. It also has a thread on, so for removing. It's not like the Chinese ring, the old style one that you sort of a nightmare to get out. But anyway, I thought that would just be interesting to let you know about what's around. And then finally, in terms of coil, the Gynifix, so we do fit these in Oxford. We like to fit them under ultrasound guidance. And that's basically because, as you can see, you can see from the device, the picture at the top, they're little copper beads on a thread. And then there's a little knot at the top, and the knot is actually embedded into the myometrium. So on the ultrasound image, you can't see my cursor, can you? But can you? Yeah. Oh, I can't see it, so I can't see where I'm putting it. But the knot is, you can see in the myometrium, that little sort of whiter area, that's where the knot is implanted in the myometrium, and then you can see all the whiter dots in the endometrium, and that's the Gynifix appropriately sited in the uterus. And again, we find that these are really good for women who have not tolerated the framed device for whatever reason. So any questions about the types of coils? Anyone got any experience of fitting anything other than the Mirena? No questions? Veronica?
Thank you. With the Gynifix, if the knot is embedded, is it difficult to remove?
No, it's usually pretty straightforward. You just give it a little gentle tug, I'd say, or maybe I shouldn't use the word tug, gentle traction, and it usually comes away very easily. It's a little bit more, there's a little bit more of an out to the fitting procedure. So it's the usual crampiness, and then I usually say to women, you might get a bit of a sharper pain now, ouch, over and done with within a few seconds. So not a massively big deal, and then pretty easy when it comes to remove. Yeah, good question though. Okay, so this bit's just very much for your interest and information, really. I'm just saying that we're seeing a lot of women using apps for their reproductive health, and it's quite good to be a little bit clued up on them. So there's an app for basically everything. There's an app to monitor your cycles and your fertility. There are apps to track your bleeding on your implant. There are apps to track, as you know, probably your periods, which are really useful because it means that all of our young patients that come in can tell you exactly when they last had a period and exactly when they last had sex, etc. The one that we are seeing quite a lot of is one of the natural family planning apps. So it's called Natural Cycles. It's the one on the top left. And this is something that claims to be a very highly effective method, and as effective as the pill. You've probably had this pop up on your Facebook feed at some point. I certainly have on several occasions. And lots of women do come in and ask about it. And what I would say is, yes, natural family planning can be the right method for many women. It does require quite a lot of not work, but it's quite an intense user input, if you see what I mean. You can't just download the app and that's that, boom, stop you from getting pregnant. You do have to monitor your cycles as you would if you were following the natural family planning method in order to make it reliable. But for some women, particularly women who are, it's not the end of the world if they get pregnant, or they're quite interested in plotting their cycles, people who like graphs, it is something that is useful for some women, but I would just say treat it with a little bit of caution if I'm advising women, saying it, that there are more reliable methods of contraception. Neda, do you have anything else to add on digital contraception?
No, that's great.
No?
Just that I also get loads of adverts for it. So.
Lots of adverts, yeah. We're all bombarded with adverts for it. The other thing that I wanted to show you was this website we think is really good, and maybe at the end or in the break we can log on to it live. I tried to embed a link and it's just too complicated for me, but basically it's got a really good interactive chart where you can click on the different methods and it just shows you in imagery how effective the method is. So that's worth directing patients to, because it can instantly show them how many women out of 100. It basically has pictures of 100 women, and I think they're blue and non-pregnant, and then you click on the method and the ones that get pregnant out of 100 go pink and develop a bump. So it's a really nice way of just showing how much more effective, say, the implant is than the withdrawal method. Okay. So I think Neda's going to take the lead on this because she's our resident transgender expert.
Thank you. Okay, so another plug for another guideline. The Faculty of Sexual and Reproductive Health actually have a very short, so it's only 3-page long, a statement about contraceptive choices in sexual health for transgender and non-binary people. I think it's really good and really clear. So if you have time, do have a look at that. Why do we have a separate guideline? Well, it's because we know that in the transgender population, the appropriateness and acceptability of different methods is going to vary, because we know that testosterone therapy does not provide adequate contraception, and because pregnancy, or risk of pregnancy is an absolute contraindication to testosterone therapy, which is teratogenic. Okay, so a pregnancy in someone who's taking testosterone would be an unintended pregnancy on someone who's taking testosterone would be a very bad outcome. Okay, just some definitions so you know what we're talking about. When we see trans woman, we mean assigned sex of male at birth but identifies as a woman. When we say trans man, we mean assigned sex of female at birth but identifies as a man, and this is the group that as gynecologists we predominantly need to know about. And non-binary, any gender identity which does not fit the male-female binary. Okay, so who needs contraception? Anyone who is assigned female at birth, i.e. they have a vagina, uterus and ovaries, okay? And who has not undergone removal of any of those organs, who does not wish to conceive, and who is having vaginal sex, okay? What options are suitable? So there are no specific restrictions on account of gender alone, but the kind of interactions might be important if someone's taking hormonal therapy. So the progesterone-only pill, the IUS, the implant and the depot do not interfere with hormone regimens and may have the additional benefit of amenorrhea. The IUD does not, again, interfere with hormone regimens, but it might be associated with some unpredictable vaginal bleeding. The combined pill is not recommended in those who are undergoing testosterone treatment, and that's really just for very obvious reasons. You don't want to undo any of those androgenic effects. And all methods of emergency contraception are suitable. So just to summarise that, if someone is a trans male, you can give them any method of contraception except for the combined pill if they're on testosterone. If they opt for the copper coil, tell them there might be a risk of bleeding. Okay. And just want to really emphasize that this is really important because a lot of people who are trans do not get counselled about the fact that they could have an unintended pregnancy. They don't get counselled about the fact that testosterone is not adequate for contraception. And we actually see there's lots of surveys actually demonstrating that trans people have a higher rate of unintended pregnancy than cisgendered people. And finally, just talking a little bit about COVID and contraception and what's changed, because this may be of interest to you. So a lot has changed in our department actually since COVID, as I suppose it has in every department. And there's been a lot of new guidance, particularly around methods of contraception and how long you can use them for. So the FSRH has released some guidance which is supporting the extended use of long-active methods for people who have them fitted already. Okay, and part of that is trying to kind of decrease footfall during COVID and unnecessary attendance to the clinic, and part of that is because there is some data demonstrating that with extended use of LARC, there are still very low rates of pregnancy. Okay, so the Mirena Levocert, although licensed for 5 years, we're kind of recommending that it probably it can be used for contraception for 6 years. The implant or Nexplanon for 4 years, and the 10-year IUD for 12 years. Okay. In general, when people attend, and I should add actually that if people are not completely happy or comfortable, that we can absolutely prescribe them the contraceptive pill on top, for example the POP, until they come for their removal and refit. In terms of removals of long-acting methods of contraception, we actually suspended that completely during the first lockdown, recommending that it's not a good time to, advise pregnancy with everything that was going on with the pandemic initially. With the second lockdown, I mean, we have started removing larks. Obviously, it's difficult to counsel people about risks around COVID and pregnancy and what's going to happen to services if there is, you know, a large second or third or fourth peak. Okay. And we're doing a lot more remote prescribing now. So we're actually prescribing the progesterone-only pill remotely. The combined pill we're prescribing remotely if someone has a recorded blood pressure or BMI, well, blood pressure really, in the last year. And if not, we just get them in for a much briefer appointment where we can measure their blood pressure, but we do almost all of the counselling over the phone, which I think has actually been a really positive change. Lots of our patients think are finding it much more accessible, a lot easier just to be able to come and do everything over the phone and come and pick up a prescription. Okay, so we've talked to you for quite a long time. So what we're going to do now is do a very brief quiz, and then we're going to give you all a break. So I hope that sounds okay. I'll carry on with the quiz.
How should we do the quiz then? Should we get them to
Hmm.
shout out the answers?
Shout out or type in the chat?
Type in the chat.
Yeah.
Yeah, sorry. So we were, let me come on the screen again. We were going to try and do this through Mentimeter, and then we realised last minute that our password had expired.
Yes.
So I suggest if people are comfortable to just like be bold and shout out the answers, that's great. Otherwise, I'll keep an eye on the chat if you prefer to type them in. Okay.
Excellent.
Neda, take it away, Quizmaster.
Question number 1. What is the failure rate of condoms with typical use? Is it 1%, 2%, 8%, 12%, or 18%?
18.
18%. Well done.
18.
We had the answer earlier in the session. Excellent. 18%. What is the failure rate of the contraceptive implant with typical use?
0.05%.
Yes, 0.05. So, and that's compared to sterilisation, which is 0.5. Which of the following statements regarding emergency contraception is false? So levonorgestrel is a synthetic progesterone and acts by delaying ovulation. Ulipristal is a progesterone receptor modulator and acts by delaying ovulation. The copper coil is toxic to egg and sperm and prevents implantation. All methods of emergency contraception have pre and post ovulation effects.
Is it D?
That's right, it's D. So which is the only type which has any post ovulation effect?
The emergency coil.
Yes, the emergency copper coil. Well done. What is the window period for ulipristal acetate? 2 days, 3 days, 5 days, or 7 days?
5.
5 days, absolutely. And remember, that's the most effective form of oral emergency hormonal contraception. A woman requests the emergency copper coil. She has a regular 28-day cycle. She had sex on day 1, 3, and 5 of her cycle. She can have the emergency copper coil fitted up until which day of her cycle? 10, 14, 21. Someone said 19. Yeah, can you explain why it's day 19?
Because it's up to 5 days after her probable ovulation on day 14.
Yeah, absolutely. And just to reiterate that if you're within 5 days of your earliest possible day of ovulation, then it doesn't matter how many times you've had unprotected sex that cycle. Okay, so absolutely the correct answer is day 19. How about if we say her shorter cycles are actually 30 days? What does that change to?
21.
21. Well done. So 30 minus 14 plus 5. Someone did point out to me that you could just minus 9. I personally prefer to just go through it logically. And I think it's important for your understanding so that you remember why it is that we do that. Okay. So the combined hormonal contraceptive pill is contraindicated in patients with which of the following? Family history of breast cancer, family history of VTE, BMI of 30, current smoking over 5 a day, or history of migraines with aura.
Migraine with
Absolutely. So it's contraindicated in people with a history of migraines with aura because of the significantly increased risk of stroke. So I know I've mentioned the UK MEC a few times. It is your best friend when prescribing contraception because it describes the kind of cautions for every method of contraception with pretty much every condition. And you can see here that the combined pill, I can't see my cursor. But you can see you can't give it because it's a UK MEC 4 if you have a personal history of VTE, but the family history of VTE depends on the age of the relative. So it depends if the relative was under 45 or over 45. A trans man attends the clinic who was on hormone therapy, testosterone, amenorrheic, and who has never had surgery. He had sex 2 days ago. Which of the following statements is true? There's no need for a pregnancy assessment. He's eligible for any method of hormonal contraception. He's eligible for a copper coil only. He's eligible for contraceptive methods that contain progesterone.
It's B, right?
B, in a way, we could say it's B, but the fact that he's on testosterone therapy is making us think actually we wouldn't give the combined hormone. So if he wasn't on testosterone therapy, B would be correct. But because he's on testosterone therapy, we know that the combined pill, the estrogen and that could counteract some of the androgenic effects of the testosterone. So it's not B for that reason.
D.
D. So it's D. So he's eligible for contraceptive methods that contain progestogens. And building on this answer, he would also be eligible for the copper coil. Okay. So a few questions about postpartum contraception. AV is 5 weeks postpartum. She has been partially breastfeeding since delivery. She mentions that she had sex for the first time since delivery 4 days ago without a condom. She is not on contraception. Which of the following methods of emergency contraception could you offer her? Levonorgestrel, ulipristal acetate, copper coil, or a combination, or none?
D.
Why do you say D?
Well, she's 4 days post-delivery, so the levonorgestrel wouldn't be licensed, and she could have the copper coil. It's just the ulipristal acetate I don't know about.
Yeah. So this is a deliberately very, very tricky question, and you're quite right that levonorgestrel is only licensed for 72 hours. However, there is a reason that we can't give ulipristal acetate.
She's breastfeeding.
Yeah. So you could give it, but she would have to express and dump that milk for 7 days. Okay. So this is a difficult question. In general, I would say the correct answers would be either levonorgestrel or copper coil, or just the copper coil. Now, I know levonorgestrel is licensed for 72 hours, but it can be given off license for longer than that if there are no other suitable options. Okay, so that is a tricky one. Which of the following methods of ongoing contraception could you not offer her?
She
Combined
can't.
hormonal.
Combined.
The combined pill, yeah. The combined pill would be the only one that you might not be able to offer her depending on her VTE risk. The implant, injection, IUD and POP you could definitely offer her, okay? So CD is a 51-year-old woman who attends to discuss changing her copper coil. It was inserted 5 years ago. She has regular periods. What would you advise her? The answers are long, so I'll just let you read them. Any thoughts or anything in the messages, Annie?
Callum says C.
Yeah,
Callum
it's
has
C.
it. Callum says C, and that is correct. Well done, Callum. So she can continue to use the coil for contraception until she's 55 or until 1 year after her last period. So if if someone has a copper coil inserted after the age of 40, they can continue to use it up until the age of 55, or after a period of time after their last period, depending on whether they're under 50 or over 50. Okay, so C is the correct answer. EF is a trans man who is on hormone therapy testosterone. He's never had any surgery. He's not had any periods since starting testosterone. Oh, we've already had this question, haven't we? But just for emphasis, what would you advise him regarding contraception? Oh, we've said it already.
Sorry.
That's our fault. Sorry, D. Yeah, absolutely. So it's good. Repetition is good for learning. That's fine. So we bombarded you with lots of information. So we're going to take a little break now. Shall we say 5 minutes?
Yeah.
Annie?
So we'll start back at 11:35.
11:35.
Is that all right? Quick comfort break.
Great. See you all at 11:35.
Great, thanks.
Okay, I'm on. Okay. Right, hi everyone. Hope you all managed to grab a quick cuppa. So over the next, I don't know, 10, 15 minutes or so, we're just going to try and pick out a little bit about how you can use contraception for non-contraceptive purposes. Oh, hang on, my slides have stopped moving on. Why do they do this sometimes?
That's annoying.
Aha. So we've called this contraception the secret weapon. So I'm just trying to encourage you to think about contraception a little bit more widely and become familiar with the contraceptive methods so you've got them in your armoury to use for various gynecological conditions and even, you know, wider than gynae conditions. So we think contraception can be good for everything, and we're not biased at all. So some ideas from you out there. So we've touched upon a few of the things today already. So if you can all shout out to me, what can contraception be good for other than preventing pregnancy?
Regulating period.
Menorrhagia, yeah, correct. Was there another one?
Endometriosis.
Endometriosis, yeah, very good. So endometriosis and more generally pelvic pain.
You can use Dianet to treat acne.
Correct, good for the skin. Anything else?
The timing of the period?
PCOS, yeah. The timing, sorry, I missed that, sorry.
Timing the periods?
Absolutely. So that's one we often, so timing of the periods, and that might be for gynecological reasons because you want to reduce the number of withdrawal bleeds, but it might also just be for lifestyle choice. So, you know, the modern day woman doesn't necessarily want to be having periods all the time. So yeah, absolutely. Anything else?
HRT in premature ovarian failure. I think women tend to prefer using contraception rather than HRT.
Yes, so we'll talk a little bit about that. Yep. It's a sort of developing area. I don't think we have much kind of data on that, but we'll talk a little bit about that. Anything else you can think of? I think that's most things. I think the only thing we haven't mentioned that I've thought of is PMS, perhaps. Pelvic pain, including endometriosis. For prevention of endometrial hyperplasia, and that might be in premature ovarian failure. That will be in perimenopausal people or postmenopausal, and also bone protection in women with premature ovarian failure. And then just generally, the last slide is just generally for health and well-being. So there are a lot of other pros to taking contraceptive methods that we're going to talk a little bit about. So in terms of heavy menstrual bleeding, I think there are three main go-to methods that we tend to recommend as a sort of first-line approach to having heavy menstrual bleeding. And I'm sorry if this is teaching you to suck eggs, because I'm sure you already do a lot of this in your clinics. But essentially, I probably should have put the IUS right at the top, because that's usually the first line and the best thing for managing heavy menstrual bleeding. And that's been shown to decrease the number of bleeding and spotting days over time. So all dose levonorgestrel IUSs do that, so they decrease the bleeding and the spotting. But we also know that the 52 milligram is better at doing that than the slightly lower dose methods. So we see a 90% reduction in blood loss at 12 months of using a 52 milligram levonorgestrel IUS. The other things that we tend to go to in terms of contraception to manage heavy menstrual bleeding are either the injection or the combined hormonal contraceptive methods. So the injection is a progesterone-only method, so it can cause irregular bleeding, but it is a much higher dose of progesterone than in the other lower dose methods. So it does tend to lead to quite high rates of amenorrhea, so about 50% at 12 months. That amenorrhea increases with the duration of use, and is similar both for the IM version and the subcutaneous version of the injection. If you're only using the injection for bleeding control or not for contraception, you can also adapt or adjust when you have the injection. So for a woman who says, actually, you know what, I start bleeding every time at about 10 weeks, I start bleeding and I have a really heavy period, bring the injection slightly closer together. So you're giving them every 10 weeks. If you find that actually you've got someone that's not using it for contraception and they can last 16 weeks without having a bleed, spread it further apart. And we can adjust the doses slightly, give half an injection, various different things that you can do with that. Combined hormonal contraception. So in terms of managing heavy menstrual bleeding, we think evidence seems to suggest that the combined vaginal ring is actually the best combined method at cycle control. So it provides a very low, steady dose of hormone release because it's in the vagina for 3 weeks. You don't get your daily fluctuating dose that you get with an oral method. So it gives you a very consistent hormonal level, and that seems to be very good for cycle control. We see low rates of breakthrough bleeding with the combined vaginal ring. But essentially you can use any combined hormonal contraception to try and reduce the heaviness of the menstrual bleeding. So in itself, all those methods, if you use them in a traditional regime, so for 3 weeks and 1 week off, are likely to reduce the heaviness of the bleeding. But what I'm going to remind you a little bit more about is that you don't have to take them in that traditional way, and particularly perhaps in women with heavy menstrual bleeding, you might want to slightly alter the regime of how they're using that and actually eliminate or reduce the frequency of their bleeds. So the next thing that we mentioned is pelvic pain. So, you know, there's not a huge amount to say on this. You can actually use depending on the cause of your pelvic pain, you might use any of these methods to help with pelvic pain. The IUS, again, is probably the first line recommended method for managing pelvic pain, whether that's associated with endometriosis or otherwise. It is likely to, as we said, reduce your bleeding and lead to amenorrhea. And often, if women do have troublesome periods and painful periods, even if they have pain outside of those periods, if you then get on top of the period pain, make the periods lighter or go away altogether, then their other pain can improve as well. Combined hormonal contraception can be very good for pelvic pain, particularly cyclical pelvic pain. So again, we'll talk about the extended regimes on the next slide, and depot. But again, you can try the POP and implant. Some women will be amenorrheic on the POP and the implant. So that might, particularly in the young ones that maybe aren't keen to try an IUS. So I don't know if any of you have sat in on any adolescent gynae clinics, but they'll often try maybe an implant with a POP on top if they're getting regular bleeding on the implant. And you can sort of double up on your contraceptive methods, achieve amenorrhea or oligomenorrhea, and help with pelvic pain and bleeding in that way. So we use a lot of tailored regimes for combined hormonal method of contraception. We're really trying to encourage women to think about developing, using a regime that fits in with their lifestyle and their needs. So the Faculty of Sexual Reproductive Health have at last come out and said that we recognised that tailored regimes of combined hormonal contraception have equivalent efficacy, safety and compliance to the standard traditional 21 days on, 7 days off regime. In addition, they have high rates of satisfaction, and they are associated with reduced frequency of withdrawal bleeds and the associated symptoms. And in terms of contraception, it is likely that if you're reducing your pill-free intervals, the frequency or the length of your pill-free intervals, you're going to gain better pituitary and ovarian suppression. So the likelihood of escape ovulation, so your ovaries kind of waking up and ovulating at the end of a pill-free interval, is going to be lower if you're having fewer or shorter pill-free intervals or hormone-free intervals. So we think it's a bit of a no-brainer to offer these different methods for women. There are some pills that are licensed for extended regimes, so the newer 4th generation ones that are coming out, they still tend to be pretty pricey. You can actually do it with any type of combined pill or a patch or a vaginal ring. And what do I mean by tailored regimes? Oh, sorry, forgot about this slide. So this is what the faculty says, basically. It's a bit where it says, it's fine, it's safe, we should be telling women about different regimes. And if you struggle to get through and explain lots of different methods, then you're more than welcome to access the leaflet that we've developed. So there are 2 leaflets at the bottom of this page, which you can link. You can basically follow that link, and one of them is OUH, one of them is Oxford Health, but they have some diagrams that kind of help to illustrate tailored use to women. So what do I mean by tailored use? So this is the standard way of taking the pills. So when the pills were developed back in the 60s, it was thought, for multiple reasons, that women would still like to have their period. Okay, so they'd still like to have a bleed every month. Now, we spend a lot of time explaining to patients that actually that isn't a period. It is an artificial withdrawal bleed or a fake period. It is not a reassurance that you are not pregnant. There is no real physical benefit to having that withdrawal bleed for the vast majority of women, particularly those just using this as contraception. So you can miss out the bleed safely. So this is the traditional way of taking it. And some women do still like to take it the traditional way. But there are other ways. You'll be very familiar with this, I imagine, because I know in gynecology from my gynae days, tricycling is a very common way of recommending to take the pill. So that means 3 packs back to back, then a break, and then another 3 packs. And you can have up to 7 days break, but we tend to recommend 4 or 7 days break. Essentially, you should never have more than 7 days off from your pill, because then your ovaries start to wake up, you can ovulate, and be at your highest risk of pregnancy at the end of an extended pill-free interval. So the other way that a lot of women are using their pills now, and I'd recommend that this is quite good and particularly worth considering for women with pelvic pain or heavy menstrual bleeding, is the flexible extended use. So that basically means taking your pill continuously, so 1 pill every single day. And you can carry this along for as long as you want. Some women will get some breakthrough bleeding with this method. And we tend to advise if you bleed for 4 days or more, so for 4 days in a row, stop your pill for 4 days, so have the following 4 days off, have a bleed, and then restart. So you're kind of tailoring your pill to when your body wants to have a bleed, in a very non-scientific way of explaining it. So that's how a lot of women use it. It's really safe. We encourage women to use it like that. Now, if a woman does not have any breakthrough bleeding, or if she has some breakthrough bleeding, but it's not actually bothering, it's not significant, she can just take it continuously. So taking the combined pill continuously, never stopping, you're less likely to get pregnant because you're less likely to sort of miss pills at important times. And you can be rendered amenorrheic, which may be really good for lots of other gynecological reasons. So don't be afraid to recommend these ways of taking the pills. Any questions about tailored pill use? Okay, moving on then. PCOS. So the 2 methods that we tend to advise using in women with PCOS are the combined methods and the IUS. And there are a couple of different things that we're thinking about in PCOS. So the one thing is that women with oligo or amenorrhea, we want to prevent endometrial hyperplasia. So we know these women are often at risk of endometrial hyperplasia and then consequently at higher risks of endometrial cancer, particularly if they have the syndrome, the sort of metabolic syndrome associated with PCOS. So we want to prevent that. So there are 2 main ways that are licensed really for prevention of that. So the IUS is a very good way of doing that. So you can put in an IUS, and similarly for when you use it for HRT, it's very good at preventing endometrial hyperplasia. The other thing is that you can give a combined hormonal pill, and you can use that to induce withdrawal bleeds. So that would tend to be used either tricyclically or in a traditional regime, where you induce at least 3 to 4 withdrawal bleeds a year to reduce the risk of hyperplasia. Some of the combined hormonal methods are also particularly good for helping with some of the other side effects of polycystic ovarian syndrome. So skin, so someone already mentioned Dianet. That is, I can never say, but it's cociprondiol. Can you say that any better than me?
That sounds right.
No. Anyway, so that's the progestogen that's in Dianet. We don't tend to use that as a first-line contraception because we know it is associated with a higher VTE risk. But if a woman particularly wants to help with her skin, then that is an anti-androgenic pill, and it's known to be very good for that. And the advice is usually use that for a year and then change to a slightly lower risk pill. But that's very good for clearing up the skin. Generally, all the pills combined pills tend to be pretty good for the skin. And for hirsutism, so giving an estrogen-containing method can help women with those issues. So those are the sort of main things that we can do, main ways in which we can use combined hormonal contraception for PCOS. If we're going to be using a CHC other than Dianet that's already mentioned, the anti-androgenic ones tend to be better. So we call these the 3rd generation combined hormonal contraception. Combined hormonal contraceptives, and they contain the progestogens desogestrel, drospirenone, and gestodine. And these are just the slightly newer progestogens that have been developed that are thought to be anti-androgenic and therefore good for the side effects of the symptoms of PCOS. So nearly there now. So endometrial protection. We talked a little bit about this already, so I won't dwell on it for too long, but the Mirena is the only method that is actually licensed for endometrial protection for use as part of an HRT regimen. But as we've discussed, CHC can be used for endometrial protection in PCOS. And I think it's worth mentioning here that all progesterone-only methods are likely to cause thinning of the endometrium. So we know that women who are on the depot for a prolonged period of time have really thin, if you scan them, you barely see an endometrium. It's really thin. The POP and the implant both lead to very thin endometriums. So in contraception, we tend to think, oh, you know, those methods are probably really good at managing, you know, avoiding the risk of endometrial hyperplasia and PCOS. But I think we just need to be a bit cautious with that because they are not licensed methods and they're not recognised in the guidelines as being methods to prevent endometrial hyperplasia. So PMS, essentially, there's always a bit of trial and error with contraception, and the same goes for when you're trying to manage other conditions with contraception. But anything that inhibits ovulation, inhibits a woman's own natural fluctuating hormonal cycle, may help with PMS. So you can pretty much use any of the anovulatory methods. One that we think is actually particularly good for women who are, so a lot of the women who are on some of the sort of the mood disturbance drugs that can be enzyme inducers are on the Depo-Provera because they're on enzyme inducers. But equally, the Depo-Provera is really good at subduing the ovaries, so getting, you know, really dulling down the own natural cycle. So some women will find that actually the Depo-Provera is really good for their mood if they have sort of serious monthly fluctuations in their moods. So bit of trial and error, but that's what I would recommend trying for PMS, is just anything initially that that eliminates the ovulation. And someone also mentioned premature ovarian insufficiency. So there's still an ongoing debate, I think, about whether the combined hormonal contraception can be used instead of HRT in young women who go through POI. we don't really know at the moment whether it is as good at protecting bones, but we do know it has some protective effect against osteoporosis. And we do think that it is likely to be more acceptable to young women. So a lot of young women are happier to take the combined hormonal contraceptive methods than HRT, because they're doing the same thing as women their own age. And it also can allow them to have a bleed and feel normal, feel like they're having periods like their friends, you know, and other people their age. So I think there are ongoing studies looking at that at the moment. The other benefit of CHC rather than HRT is that women can obtain it for free. And HRT women often have to pay for 2 prescription charges because they have to pay for the estrogen and the progesterone, whereas contraception is free on the NHS. So although that isn't a big issue for everyone, that is something that can affect decision, but it can be used for HRT. And then finally, just a little plug that, you know, I know hormones get a bit of a bad rep sometimes, and definitely we're going through an era of, no, I don't want chemicals in my body, I don't want anything artificial. But actually, estrogen tends to make us feel great. Look at what happens when you go through the menopause. A lot of women feel rubbish, don't they? So hormonal methods, albeit artificial hormones, can certainly make life better for a lot of women. So they can improve your skin, they can improve your mood, they can improve your hair, they can allow you to adapt your lifestyle so that you control when you bleed, how much, if at all. So, you know, I know we're a bit biased because we're contraception specialists, but just a bit of a plug for contraception for everything, basically. Plus, let's not forget, and we do often take this for granted, contraception allows people to enjoy their sex lives without the fear of unplanned pregnancy. And that hasn't been around forever. So that's only been for the past 60 or so years that we've had reliable forms of contraception. Yeah, just a little pro-contraception plug at the end. Okay, that's my bit about contraception for gynae. Does anyone have any questions or comments or experiences to share about using contraception for gynae reasons? Anything, Neda?
Nothing on the chat.
Nothing. So everyone's either disappeared or there's a stunned silence. Thank you. What time is it?
It is almost 12 o'clock.
Almost 12 o'clock. We've got half an hour. Great. So now we're going to do a couple of case studies, and they're a bit more along the STI, sexual health theme of things. But we tried to think of a couple of cases that you probably do see on a pretty regular basis on your kind of gynae on-call take or whatever. Please do interact because I'm sure they should be hopefully pretty straightforward cases for you. So the first case study is, so a 23-year-old Nullip is sent over from A&E while you're on call for gynae. She complains of a 3-day history of worsening lower abdominal pain, but she says actually for the last 2 to 3 weeks she's had some lower abdominal pain getting progressively worse during sex and a little bit of postcoital bleeding. So what other questions do you want to ask her? And then what tests and investigations would you do, and what examination would you do? So let's start with, what other questions do you want to ask her?
Any contraception?
Yeah, contraception. So she tells you that she has an IUD, so a copper coil in situ, which she's had there for the past 2 years. Anything else?
When was her last period?
When was her last period? Very good. So assessing pregnancy risk. Anything else?
Any recent change in sexual partner?
Yeah, good. So you want to do a good sexual history.
Is she up to date with her smears?
Up to date with smears. Very good.
She's only 23.
She's too young for smears. Yeah, correct. Well spotted.
Any STIs?
Okay. Any STIs? Good. So, yeah, so these are the main things I thought you'd want to ask initially. So sexual history. So from her sexual history, she says she last had sex 2 days ago. It was with a casual male partner who she's been having sex with for about the last 3 weeks from the UK, and she did not use a condom. Prior to that, the last time she had sex was 3 months ago with her ex-boyfriend of 2 years. She didn't use condoms with him. No other sexual partners in the last 6 months, and the last time she thinks she had an STI screen was before her IUD fitting. So the IUD fitting was about 2 years ago. She says she hasn't particularly had any problems with it since then, but she's never been able to feel her threads herself. Her last period was around 2 weeks ago. She's a bit vague. She hasn't got an app, unfortunately. What is your differential diagnosis at this point?
PID, and she also could be pregnant.
Correct. Good.
Misplaced marina.
Sorry, I missed that. Okay, so what investigations do you want to do pretty soonish? Brilliant. Great. Rule out an ectopic pregnancy. Pregnancy test. What else?
Urinalysis.
Good.
We need to examine her.
Swabs.
You need to examine her. Swabs. Okay, good. So the 3 investigations I thought were the most urgent were a PT, urine dip, and then an STI screen. Are you all happy? You know what swabs you're taking for doing STI screens? So it might be different in all the slightly different in the different trusts, but essentially what we would class as an STI screen is vulvovaginal swabs. So NAT tests are the best swab that you can do. And in OUH, you can get a NAT one swab that tests for chlamydia, gonorrhea, and trichomonas. In other places, I'm not sure if you get TV on your NAT test. They don't do it in every lab, but that is what I would recommend doing. So taking a vulvovaginal swab, a woman can do it herself. You'll probably be examining her, so you can do it at the same time as the examination. But ideally, you want to do it on the vulva on the outside to pick up any urethral. So sort of sweep it over the outside of the vulva and the urethra, and then inside the vagina. Doesn't need to go anywhere near the endocervix. It's actually more reliable doing the vulvovaginal swab. Anything to add on that, Neda?
No, I would agree. And just for the Oxford lot, just to say it's a purple swab that we use for the NAT screen, but not to be confused with the purple swab that is for MRSA. Okay, because I remember, at least when I was in SHO, lots of people were sending off MRSA swabs, which were coming back as, as wrong swab for chlamydia and gonorrhea. So whatever trust you're in, if you're not sure, go and have a look in advance. Make sure you know what type of swab your NAT swab is, so you don't send off the wrong one.
And it can be quite a good quip if you're if you think there's some confusion in it, and you want a little quip. You can develop some nice posters with pictures of the right swabs and just stick them up in your ward, and it's pretty simple and straightforward, but it does help because quite often there is a bit of confusion. Okay, so you're going to do all of these investigations and then you're going to do an examination. What are you particularly looking for in your examination?
Observations, including like temperature.
Correct, good. You make sure she's not septic.
See if you can see the strings.
Good, yeah. So you want to know if she's perforated her coil. Could be a differential, couldn't it?
Any sort of cervical excitation.
Yeah, cervical excitation. Sorry, there was another one in the background.
Any purulent discharge?
Yeah, good.
Any abdominal pelvic masses?
Yeah, very good. So your usual thorough examination. So this is the results of your findings. So she's got some suprapubic tenderness, no guarding or rebound. Let's say she hasn't got a temperature currently. Outside of the vulva and the inside of the vagina look normal. Her cervix looks pretty normal, possibly a bit red, has a small ectropion, and you can see her threads quite clearly, about 4 centimetres. You then do a bimanual examination, and she does have cervical motion tenderness. She's got an anteverted uterus, which is pretty tender, but you can't feel any masses in the adnexa. What's your diagnosis and what do you want to do next?
PID, treater with antibiotic.
Yeah. So I did say these were straightforward cases. So she's got PID. Okay. So what antibiotics are you going to give her?
Depends whether we want to admit her or not.
True.
It depends whether we need to admit her, isn't it?
Yeah, true. Yeah, so you might give different antibiotics if you admit her. So you might give them different. You might give IV antibiotics if you admit her. Let's say that you don't think she needs admitting, and you're going to send her home and just get her started on some antibiotics.
One-off dose of azithro and then metro and doxy for 14 days.
So the BASH guidelines say doxycycline for 14 days, a one-off dose of IM ceftriaxone, and 14 days of oral metronidazole. Correct, Neda?
Yeah, yeah. And I mean, ceftriaxone covers for gonorrhea. So if you give azithro or doxy or metronidazole, you won't cover for gonorrhea. So that's why the ceftriaxone is there.
So it can depend slightly on your area and your rates of gonorrhea, but that's the kind of standard treatment regime. Azithro tends to be a kind of backup for doxy in people that can't have doxycycline. So we know that doxycycline is better at treating chlamydia than azithromycin. So we tend to use the doxycycline, the ceftriaxone, and the metronidazole regime. Other than antibiotics, so you initiate your PID according to your trust protocol, get started on antibiotics. Anything else, and I think this is the point I really wanted to bring up. I think this is the bit that more often gets forgotten. Is there anything else you should advise your patient to do?
Abstain from sexual intercourse until she needs to have a swab for treatment cure thing.
So you've done your swabs today. So I guess whether she needs a test of cure depends what the results of the swabs are. So either way, you're treating her for PID because it's a clinical diagnosis, isn't it? And often STI screen comes back as negative with PID. But if she then did get a positive gonorrhea result, then we would advise her to do a test of cure for that. We don't usually do test of cure for chlamydia because doxycycline is a very reliable treatment. But for the young ones who are at very high risk, young people are at pretty high risk of getting chlamydia, we tend to say come back at least 6 weeks after treatment for a retest. So abstain for the duration of treatment. Sorry?
Would you suggest a condom use for the next 14 days?
I would suggest abstaining from sex altogether for the next 14 days because condoms are not completely protective against STIs. What else would you recommend regarding sexual risk over the next 14 days? Or at any point?
Contact tracing?
Yes, definitely. So you'd recommend current partners are treated, and the partner treatment for PID in a male is 7 days of doxycycline. So you'd recommend that if her casual partner, if she's going to get treated, going to have sex with him again, gets treated before she has sex with him again. So ideally, go and get antibiotics within the next 14 days. He has his 7, she has her 2 weeks, and then providing her symptoms are better, they can start having sex again.
And we would say that even with just a clinical diagnosis when you see her, not dependent on tests or anything like that, on swabs.
Correct. We always say that. And I know, sometimes it's a bit dubious, isn't it? And you think it's highly unlikely to be an STI related cause. But we always do say, look, we can't, even if there's an infective cause there, and you're treated for it, but your partner isn't, you could just be passing something backwards and forwards. So it's better to both get treatment, await results, and then you can resume having sex again, unprotected sex again. Okay, so and this is the slightly controversial area. So your registrar you speak to, they're very busy on labour ward, and they say, no, just take out the coil and start the antibiotics. Should you do this?
I think officially you're allowed to wait 24 to 40 hours to review, isn't it?
Yeah, correct. So the guidance suggests generally speaking, you can leave them in. And if over the next 48 to 72 hours, things don't get better or things get worse, then you can review whether to remove it at that point, because removing the foreign body might help you to kind of get on top of the PID symptoms. But yes, in this case, I would advise not removing it. If you do remove it, so you're in a difficult position here, your registrar has said just take it out, you're going to remove it. What do you need to check before you remove it?
The last time she had sex or intercourse?
Correct. Good. So it was 2 days ago. It was without a condom. What do you need to tell her?
Emergency contraception.
Contraception.
Yeah. So you need to say to her, look, if I remove the coil, it was going to put you at risk of pregnancy. Sperm can survive for up to 7 days in the vaginal tract. We're removing the device that is preventing the sperm from fertilizing any eggs. If we remove that device, you could get pregnant from the sex you had 2 days ago. So ideally, keep the coil in, at least until that sperm have gone away. If you're definitely going to take out, offer her emergency contraception and a follow-up pregnancy test in 3 weeks' time.
Can I ask a question?
Yeah.
Firstly, if you're doing the partner treating, they get 7 days of doxy. So does that not cover gonorrhea then?
Yeah, it's a good question. So we don't give them the kind of full whack of treatment. To be fair, if gonorrhea came back as positive, we would treat them then with ceftriaxone.
Sure.
I think it's probably because gonorrhea is less common. Would you say, is that
Yeah,
why?
absolutely. I mean, the guidance around partner identification is really rare. I mean, really vague. It's kind of like, it's epidemiological treatment in a way. It's just trying to cover for organisms that we might not have been able to test for, like mycoplasma or other things.
Yeah.
So if it's gonorrhea, you're going to know from the swab test. But the doxycycline is there for other, potential organisms.
And the doxycycline is what we tend to use. So if a male comes in with NSU, so non-specific inflammation of the urethra where they produce discharge, and we don't see gonorrhea in it, then we tend to give doxycycline, because chlamydia is the most common STI, and that's treated by doxycycline. But as Neda says, it also covers for other pathogens.
Sure.
So yeah, good question. But
the other question
we do
was,
locally, but we have low rates of gonorrhea, fairly local rates.
Thank you. My other question was, if you're treating them as an outpatient and they've got an IUD in situ, are you asking them to come back for a review in 48 hours, or are you just, because they're clinically well enough to send home?
I don't think you need to. We don't do that in sexual health. I would just say, I mean, it depends how worried you are about them. You can always give them a call and review them in 3 days, or you can say, if you're not seeing if you're not feeling better within the next 3 days, not completely better, but if you're not on the road to recovery, then get back in touch with us.
Sure.
I'm a big fan of putting things in patients' hands, because I think, getting them to take responsibility for their own, because I think things are less likely to get missed that way. So I don't think we necessarily need to be bringing people time, particularly at the moment. I think it's safe, as long as you safety net and give them options if things get worse, and advice about what signs to look for if things get worse. Does that sound okay?
Yeah, that's great. Thank you.
Lovely. Thank you. So we've got one more case, which hopefully we've just got a bit of time for, which I'm going to let Neda lead on, because you're probably sick of my voice.
Thank you so much, Annie. Right, okay. I'll just take my mask off. So, case study 2, a 27-year-old admitted to the gynae ward via A&E with urinary retention, severe vulval pain and increased discharge. For the last 3 days, she's been feeling feverish and achy, and she noticed a tender lump in her groin. Spot diagnosis. So any ideas on someone?
Primary herpes?
Yeah, quite a few people have said herpes. Well done, brilliant. So how would you manage her?
She'd need to have a catheter, I guess, if she's in retention.
Yeah, and what kind of bedside test do we often do when deciding whether or not to catheterize someone?
Bladder scan.
Yeah, absolutely. So you might want to do a bladder scan. I think it varies from trust to trust. In Oxford, we often say if it's kind of over 500 mils, we'd catheterize. And below that point, we would consider based on other symptoms. How else would you manage her?
Would you give acyclovir for her herpes?
Yeah, brilliant. So acyclovir is an antiviral, okay? So it's not curative of herpes, because we know that once you have herpes, that is a virus that will stay on the skin for life. However, the antivirus acyclovir can significantly reduce the severity of outbreaks, okay? So we would give her acyclovir. Does anyone know the dose and duration of standard outpatient prescriptions for acyclovir?
Is it 300, Mike? I don't know.
I think it's 400 TDS.
That's right. So it's 400 milligrams TDS. And how long do patients take it for?
That I don't know.
5 days, I think.
5 days, yeah, absolutely. So you take 400 milligrams TDS for 5 days during an outbreak. Okay, so the earlier you can take it during the outbreak, the more likely it is to reduce the severity of symptoms, and in some cases can even stop that outbreak from fully developing. But in this case, absolutely, for this lady, we'd want to give her some acyclovir. How else would we manage her? Let's think of some other kind of more conservative measures.
Painkillers.
Yep, painkillers, lots of analgesia, and there's different ways of delivering that analgesia, isn't there?
Could we give her some lignocaine jelly?
So we'd want to give her lots of lignocaine jelly. So we use Optilube Active in Oxford, but any topical lignocaine, lidocaine would be very beneficial, and absolutely the standard painkillers, so paracetamol, ibuprofen, etc. Okay, so bladder scan and consider catheterization, acyclovir, analgesia, local anesthetic gel. You could also consider antibiotics if there's any evidence of a superimposed bacterial infection. So often with people who have a really severe first, primary outbreak of HSV, you might notice that there's kind of developing cellulitis or that kind of gold crusting that you often get over lesions that's quite characteristic of a staph infection. So you might want to consider antibiotics if there's superimposed bacterial infection. Now, you explained to her in a very lovely and reassuring way that she has herpes, but she's really upset that she's been with the same partner for 5 years and wants to know if this means he's been unfaithful. How would you answer her? This does come up from time to time on the gynae ward. I remember a few of these cases when I was an SHO of the JR.
But he could have had an asymptomatic infection. Be a long sort of.
Absolutely. Yes, well done, Harriet. So she
doesn't actually he's been unfaithful.
Yeah, so he could have had it but been asymptomatic. So with HSV, there's a lot of subclinical transmission, so meaning that people can shed the virus and spread it without having any clinical signs or symptoms themselves. What else would you say?
Would you say, on the other hand, it is possible, and she might want to consider a kind of a broader STI screen?
That's a good point. I mean, I think it's a difficult conversation, isn't it? What I would say is herpes transmission is often subclinical. There's no way to know when you got it because actually a lot of people don't necessarily have their primary kind of symptoms at the time that they acquire the virus. So there's no way to know when she actually acquired the virus. But I would also say, as you pointed out, for anyone who's presenting with one STI, we know there's always a higher risk of having other STIs. So it might be a good idea for her and her partner just to have an STI screen. Yeah, I mean, she's likely to go and Google herpes and see that it's a sexually transmitted infection and have these questions herself. So raising that and touching on that point during the consultation is also a really good idea. Brilliant. Okay, so with herpes, as with any STI, communication skills are of the essence. When we're actually giving that diagnosis of herpes as well, it's really important to be careful and mindful of the language that you use. So when I give someone a diagnosis of herpes, I always say, it looks like you've developed what we call the cold sore virus. So the same virus that causes cold sores of the mouth can cause cold sores of the genitals, okay? And phrasing it that way also kind of highlights the degree to which any genital lesions are stigmatized in a way that oral lesions really aren't stigmatized. Partner notification, not absolutely necessary, but it's important that patients know about the risk of possible recurrences and the risk of asymptomatic shedding, so passing on that virus even when they don't have an outbreak. Any questions about that case study?
Can I just ask a question, like, would any of in the cases that we've discussed, would you consider like HIV testing? Because like I know with the woman that presented with herpes, she's got a lump in her groin. So like that could, like she's obviously got herpes, but yeah, would you consider discussing that?
That's a really good question. We would recommend HIV testing as part of any standard sexual health screen. So what are the tests that we test for in a standard sexual health screen? What are the infections we test for?
HIV, hepatitis, syphilis.
So the standard ones are HIV, syphilis, chlamydia, gonorrhea, and trichomonas. Okay. in terms of hepatitis B testing, we actually generally only do that if people have certain kind of risk factors for hepatitis B. But certainly, if anyone has one STI, it's a good idea to test for the others. So I hope that answers your question. Anything to add on that, Annie? Yeah. Brilliant. So we've come to the end of our very long talk. We hope that you found that useful and that we didn't bombard you with too much information. And we've got a bit of time now. What time is it? 20 past. So we've got 10 minutes now for any questions or comments. And Annie and I are both here to answer them.
Can I ask one it's a slightly trivial question, just about ceftriaxone. We had something on the ward the other day where we had to give outpatient treatment for PID. And one of the nurses said, can you prescribe the lignocaine? And that sometimes, and the pharmacist said that was absolutely fine, but it's not something I'd come across before, where you make up the ceftriaxone with lignocaine in the syringe. Is that something that you guys do routinely or have come across?
Yes, yeah, routinely. It's a really painful injection, apparently, so we always give it with lidocaine. But to be honest, we have it as a prescription that comes up with lidocaine. So
yeah,
I'm not sure how you do it as separate prescriptions.
But you're right. If you're like in the JR, for example, on EPR, I know that you do have to prescribe the lidocaine and the ceftriaxone separately. So that nurse was correct. Yeah, you do have to.
In the same syringe.
Yeah,
they mix it up in the same syringe. Yeah.
Good question.
Anything else? So this is a more general question, and sorry that everyone else has to hear it. I've always been really interested in sexual health. I did the reproductive and sexual health masters at LSHDM.
Great.
But I feel like gynae, well, maybe it's because of COVID, but we haven't had as much exposure to kind of like the sexual health stuff, and maybe it's because I haven't been able to get to clinics. Is there any like way, I don't know, in training that we could get more involved with the sexual health side? I don't know if there's like more that I could be doing.
Yeah, so are you Oxford? Where I suppose you all come and go around different areas, don't you? Yes, and the answer is we're trying to work on improving those kind of reciprocal links, because it makes no sense as being all completely siloed. We have massive overlap in our specialties. In Oxford Sexual Health Department, I'm the educational lead, so I've got a particular interest in trying to improve that component of your programme. But I'd be very open to what we're doing currently is inadequate. I think we're doing teaching sessions, and people who are particularly interested contact us, come and have a day, a few days, come and shadow in clinic and get involved. If you're particularly keen, you can register to do your diploma in your DFSR8, so your diploma in family planning, and there are equivalent GUM qualifications that you can do as well, the STIF course, and you can register and do that through us as well. But I agree. I think we need something a little bit more concrete than that. I think we need something that's available to all. It's just establishing kind of how to do that with capacity and how to integrate that into your already incredibly busy training program. Yeah. So any ideas would be very welcome, and anyone who'd like to work on it together, also that would be great. Let me know, and we can sort of try and come up with some solutions. Do you have anything to add to that?
And also just to say, is that Lydia?
Yeah.
We also, we have lots of contraceptive projects popping up all the time. So if you have any interest in helping us, especially with your background at the London School, I'm sure you would have loads of skills to offer us as well. So you're welcome to get in touch with us.
If you don't mind sharing your email addresses, then I might just email you.
Yeah. So
you can put it in the chat.
We'll put them in the chat. Yeah, that's a good idea. We'll put them in the chat, but basically it's our name.oursurname @ouh.nhs.uk. Okay. I'll put that now.
Thank you.
Any other questions?
Yeah, I was just wondering, should we do an STI screen for anyone that has an abnormal smear as well, or is positive for HPV?
That's a good question. So the colposcopy guidelines say that anybody with abnormal smears should have a HIV test. And it says HIV test, but it doesn't give much specification about other STIs. you know, it's not an absolute requirement, but in general, I would say it makes sense for anybody who has a positive HPV test to recommend doing chlamydia and gonorrhea tests, you know. And I guess you won't be coming across a lot of these patients as an inpatient, but in outpatient settings, you can refer patients on to go to their local sexual health clinic to have a full STI screen, and that would include HIV as well. There are currently, unfortunately, not very good links between CULP and sexual health. I know in some trusts around the country, people who have a positive HPV test automatically get a HIV test, and that is not the case here, unfortunately.
Thanks.
No problem.
Thank you so much for having us. We've enjoyed remotely meeting you and teaching you today. So thanks.
Thank you both. Sorry, just before you go, I didn't catch the whole talk. I just had one question. It was related to testosterone. And you know, I see some women with low mood and things. So sorry if you've covered this already. I didn't listen to the whole talk. But someone has been, you know, low mood, and they want to have something done. The GP's helpfully or unhelpfully done their testosterone levels, and their testosterone is low. So is that something that we would treat, not treat? It's something that I've really struggled with. And sorry, this is me being selfish.
Is this kind of perimenopausal women or women of...
No, young women. I've had early 20s who've got a low testosterone.
I mean, I think I'd probably ignore that if they've got, if it's a low mood symptom. Would you say the same? I'm not really an expert.
So not mood, libido. I mean, low libido.
The only experience I have is of using it in perimenopausal women for low libido.
Okay.
But yeah, I don't think that's probably relevant.
No,
it could be that their testosterone levels are suppressed if they're on hormonal contraceptives as well. So yeah.
Yeah,
but
I mean, with one patient, she
a bit of research, and the other person, Katie Barber's quite a good person to talk to about. She's sort of menopause lady, and I know it's menopause exactly, but Katie Vincent is very.
Katie Vincent, it would be a good person to ask with the young women, and then Katie Barber for the older ones. Yeah.
Because as I say, it's always a problem when the GP's already done the bloods and the patient's like, oh, I've got low testosterone, I'm going to go and see the gynecologist. You're like, oh, I don't know what I'm going to do with you. Although one thing I have found has helped with a couple of patients is psychosexual counselling, just to kind of understand other non-pharmacological issues. But no, that was just something I thought I would ask from you.
I don't think if there's a sexual problem, you know, and then psychosexual counselling can be very useful. But if it's just a result of its own, it kind of depends what problem they're coming in with, what they're presenting with.
Okay, lovely. That's great. Was there anything from anybody else then before we let these guys go? Lydia, your hand's still up. Was that from before?
Right. Yeah. Sorry, that's from before. Sorry.
Okay, lovely. Thank you. Thank you both to you guys. That was really excellent. I'm sure the trainees have really appreciated it. Thanks a lot then.
Thank you. Enjoy the rest of your day.
Thanks so much. That's amazing. Thank you.
Thank you.
Thank you.